My name is Randy Penny, and I'm going to be your MC, your guide, your host, your timekeeper, to keep things moving throughout the day. And so welcome, everyone. I hope everybody had a good sleep after yesterday's activities. So good to see everyone. Just a couple of short little, housekeeping details. Housekeeping. Washrooms on this floor are just back down the hall and just after the elevators. There's 2 washrooms there. If you go in and the light doesn't come on, it should come on. So it should just come on as you walk in. If not, there's a little panel on the wall. Everything else about washrooms, I think you understand. You'll have noticed that some people have, lots of people have these on. Some will have written on it host, and so that's primarily our staff. And we have 2 young people, you've probably seen them here and there, Kyle and Sean. And Kyle and Sean are volunteers. They're youth who are in our program. They were very excited to be able to help out throughout these 2 days. So you'll see them as well. And so basically, if you have any questions about where to go or what's where, anybody with a host name tag or Sean or Kyle, they'll be able to kind of direct you where to go. I think that's all. So what I want to do now is call upon John Colangeli, our CEO, to begin our morning.
Thank you, Randy, and welcome back to day 2 of BrainLinks Canada Symposium. And we hope you had a good day yesterday. And I know that some folks are just, well, 6 people that registered this morning couldn't make it to last night, and we welcome you. Good to have you, and it's great to see everybody here. Last night, I talked about the mandate of the Lutherwood Institute for Children and Youth Mental Health, which we built this room in the new building especially for. And really what we want to do is bring practitioners together with researchers, and we want to share information and avoid duplicating. We all know in our field we love to reinvent the wheel. And in the Institute, we want to share knowledge nationally and try to avoid that duplication. Those of you who travel across Canada, and we have done that recently, and I'll tell you about that in a minute, you can see the development of children's mental health centers has been so varied and so different across Canada. And when you see that, you realize we all have the same issues and the same problems. We're dealing with ministries. We're trying to do good work. There's lots of blocks in our path. And we want to try to push the envelope so that we try to solve those issues and those problems. And we do it in a way that the only way, I think, is to get together on a national basis occasionally and have forums like this to help ourselves. The unique thing about a symposium format is it allows you to be a participant by asking questions, by being a presenter in some cases. It allows you to be a thinker, to sit back and say, I wonder about this idea. Might this work for me? And it just allows you to listen and take in the information. So we hope that the insights from today, that some of them, those aha moments that we all have during learning events, and sometimes that one or maybe 2 ideas that can really transform things and the way that you look at a particular problem, learning from somebody else. I call it R&D, rob and duplicate. That's always a good thing to do, so rob and duplicate if you can. We all want to share. The BrainLinks Canada is really the first national conference of the Lutherwood Institute. And really what we want to do here is look at the latest findings in brain science. And we've got a lot of, we have many of the top names here in this room, both practitioners and brain scientists and researchers. And we want to ask, and this is the question I'd like you to keep in your mind today, how do we take these wonderful findings? If you talk to some of these folks, one of them was telling me the other day, there's been more advances in the past 10 years in brain science than in the past 100. Think about that, the implications of that. Are we taking the findings? How do we take the findings and put them in a place in your, especially the practitioners, as you go back, you work with kids, you're responsible for entire systems that work for, that do good things in kids' lives. How do you take those wonderful findings that are really hard won? They're expensive. A lot of people have spent their lives developing this knowledge, and how do we make it real in kids' lives? How do you make it real in your children's mental health center? So I ask you to keep that in mind. We purposely wanted to make this gathering small. We wanted it to be intimate, because part of what we want to do is have a learning network that emerges out of this. And so I encourage you, if you came with somebody, I know it's always more comfortable to sit with that person, especially if you're from away. Try to sit with somebody different at lunch, during coffee. Please make an effort to make a new friend and exchange information, because I think that will be very valuable to you. So that's why we made it so small and so intimate. We want you to get to know each other and to ask questions of us and each other. You're welcome to ask questions throughout today, and don't be afraid. Please be interactive, and don't hesitate at all to do that and to ask questions. There are people here from Halifax to Calgary, and I think you'll find a lot of history and a lot of incredible stories in children's mental health. So there's some informal learning that you can do as well. Last night at the community event, when Barbara Aerosmith Young spoke, I acknowledged three people or three organizations that have made our institute a reality. So when we came up with this dream, the Cowan Institute, Cowan is an insurance company that is based out of Waterloo and Ottawa and some other places. The Cowan Institute gave us a significant amount of money to get going. The Lyle S. Hallman Foundation, which is a local foundation that loves kids, did the same thing. But the Kids Health Links Foundation, and that's Basil. Basil is right here, Papavangelou. And Basil, we're going to ask. He hates when we do this. He hates this. But Basil has been a real champion of children's mental health and infant health, and he paid for our staff to go across Canada to find out who the go-to organizations were, and he's been a benefactor for our kids and for this initiative, and continues to be a champion for children's mental health. So we're going to ask Basil to speak to us at lunch and address the crowd. Alrighty. It's now my pleasure to introduce Dr. Ian Manion. Ian is going to talk to us about the hot 10 topics in child and youth mental health, kind of like a Letterman thing, you know? Oh, come on, Ian, you're a funny guy. Ian is a clinical psychologist, and he's a scientist practitioner with decades of experience. He is also a professor at University of Ottawa in the Department of Psychology. Most of us here in this room and beyond know Ian as the executive director of the Ontario Centre of Excellence in Child and Youth Mental Health in Ottawa. And it is through his passion, leading his team, that Ian has really put that place on the map in the past several years. And if you're from Ontario, you know that organization, and it's getting known far beyond our borders too. And it's at the center of children and youth mental health in Ontario, and it's a great resource for all of us. So we appreciate his hard work in that area. One thing you'll learn if you talk to Ian, he speaks about staying in clinical practice and research too. He's very intent on staying in the field. Youth depression and suicide are important to him. He does counseling. He's in the field, and he continues to do a lot of research. He co-founded YouthNet Réseau Ado, a bilingual community-based mental health program that is now throughout Canada and going into Europe as well. Most of all, I would say that Ian is a very passionate advocate for our kids and for the work that we do. And over the past several years, he has gone from the provincial stage to national to international, and he's carried that passion through with him. So I introduce Dr. Ian Manion.
Thank you, John. Good morning. This will not be Letterman. So I was incredibly flattered when John asked me to come and participate in this day. It's we talk about the work that the center does. Well, we're huge fans of Lutherwood and your innovations, and talk about leaders. I think there's one sitting right here. So there's a bit of a caveat to my presentation today. So these are my top 10 hot topics in child and youth mental health. You may not agree. I have not done a study to determine whether these are the top 10 topics or not. And those of you that know me as a researcher are probably amazed that I didn't do a study on that. You may or may not agree. So just stick with me. I have tweaked these. This is the second time I've presented them. And between presentations, 3 of them have changed. And I think that speaks to our field, which is continuously changing. So let's see if this actually works. The first topic, and if you're in Ontario, this is something that you're having nightmares about perhaps, and that's transformation. And I think this quote says it quite well. There comes a time when it is right to depart, even though the destination is uncertain. And I think in child and youth mental health in Ontario, we realize that the system or the non-system that we have is not tenable. It's not meeting the needs of all children and youth that could use some support. And it is not sustainable. So when we start talking about transformation, we're talking about a number of different things that are viewed as now necessary elements in what's going to be a transformed system. They're listed here, and again, those around Ontario know some of these keywords, but there's a whole shift from looking at agencies to looking at communities. What is the core business that we should be doing? What's mental health? What's mental health care? And where does it start, and where does education come in? And where does health come in? Where does child welfare and youth justice come in? The links between all of these things. We're not very good at distinguishing our distinct roles or even working together collaboratively. You'll see near the bottom of this list, evaluation for impact, data integration, quality of service experience, maximize. The word evaluation will probably come up about 20 times during the presentation. Slight bias on my part, and my Director of Evaluation and Research is sitting right there. So I have to make sure that I say it several times or she's going to be disappointed in me. Second hot topic right now is a whole government or a whole community approach to child and youth mental health. And this is very different than what we've done historically. This isn't about organizations. This isn't about a ministry. It's really about how do we do our work collectively together in a different way? How to reorganize even our language, our understanding of what we should be doing in child and youth mental health. That means we have to really question some of our fundamental beliefs, and we have to undo some history. So history about how government's organized itself, history about how perhaps we've organized our services, history about what we think prevention, promotion, early identification, intervention, maybe even chronic care in child and youth mental health means. So it's a fundamental change, and change is really hard. Another way of looking at things, and something that I've come across more recently, is the concept of collective impact. Anybody hear this concept before? If you haven't heard it yet, you'll probably hear a lot more about it. I've kind of fallen in love with this. And I'm going to just read the first sentence. Large-scale social change requires broad cross-sector coordination, yet the social sector remains focused on the isolated intervention of individual organizations. And they talk about 5, these are our 2 really bright guys, Carney and Kramer, 5 conditions for collective impact. A common agenda. So can we have our eye on the same target? Can we agree about where we want to go? Because when we agree where we want to go, the language doesn't matter as much, and the who does what we can figure out. But if we all agree on the common goal, A lot of arguments get solved by just stopping and saying, why are we doing this again? Why are we doing this again? If we can get there, then we can work it out. So that common goal, shared measurement systems, that's part of that evaluation stuff that I'm going to keep throwing in. So if we do some stuff together, how do we know it's making a difference? How do we know that we're doing what we think we're doing and achieving the ends that we hoped that we would be having? We might speak the same language, but unless we're speaking the same measurement language, we're kind of screwed. And actually, we're probably going to be increasing burden on those we keep trying to assist and those who are providing service to those individuals, because we might have 6 or 7 different kinds of accountability structures that we have to follow, which take an awful lot of time. I know one agency that has 7 funders, 3 ministries, the United Way, and I think 3 private kind of groups. And each one has their own measurement system, their own ways of reporting and accounting, and the providers are spending more time filling out forms than seeing kids. And that's a problem. Mutually reinforcing activities, we do things because we think we can make a difference, and it has to give us something too. And I think last night when we heard the story that was told about the young man that came to Lutherwood, it reminded us that we can have a huge impact on someone's life. So what do we get out of it? We should be able to get something out of it. It should reinforce us. It should energize us. It should engage us. Continuous communication. So I'm a great believer in talking. I'll talk about the problem with this kind of talking later on, but communication is huge. And you need some leadership. Now, that leadership could be an organization, could be an individual, could be a ministry, could be an official, could be a young person, it could be a parent. But you need something that's going to be a driving force in this. The backbone, talk about backbone organization. Who's going to take the lead? Not be in charge, but really make sure that we're staying the course. And in transformation, we talk about lead agencies. And at breakfast, we talk about the problems with that. If you're not a lead agency, does that mean you're a following agency? Are you a second-class citizen? Or is a lead agency the one that provides a backbone with all the other structures that fall into place to make sure it stays online? Implementation science. I used to have a slide here that was all about evidence, and I've changed that. And then just to start, this is our view. You'll see we'll talk about evidence-informed practice, not evidence-based practice. The reality is we think that evidence-informed practice is more inclusive. It includes not just what we know from research, but what we know from practice, but grounded in the reality of those that are receiving services. And when we started talking about evidence-informed practice, we found that organizations were much more willing to engage with us because it was more respectful language. There are also limitations to what we know from evidence, from research, right? You can have this great research study done by these amazing scientists in this university, done on, for example, let's say depression. That's my area. So I know one study that amazing results. They had adolescents who were depressed, who had no other problems, from intact families. They were willing to come into therapy for 20 weeks in a row by highly skilled, trained graduate students who had supervision on call. So that's evidence. Is it transferable? Is it replicable? Is it useful for the person that I'm seeing from a one-parent family that has 4 diagnoses, is on drugs, and has been suffering, is out of school, and can hardly get anywhere? So I think there's some reality checks in this. But implementation science means that it's not just the evidence that we have to look at. It's not just finding out what people need to know and giving it to them, and magically they're going to use it. There are a number of conditions that need to be in place for people to actually start using what we already know, to embedding it not just into their practice, but into their culture, the culture of an organization. That's a huge shift. That's an absolutely huge shift. Because honestly, we believe that it's not a given evidence-informed practice that's going to make the difference. It's the culture of learning and consistently looking at information to guide your practice and have decision-making guided by evidence, whether that's at the case level, at the programmatic level, at the organizational level, or, yes, at the policy level. Do you know there's such thing as evidence-based policymaking? I'm trying to convince government that that's something they should engage in. And we're having some success in that regard. So we're only at number 3. Brain and behavior. Now, after last night's talk, I should have made this number 1 because it's such a compelling talk. But it did make my top 10. And when I talk about brain and behavior, I'm not going to spend a lot of time because you have the real experts in the field talking later on today, and you had a giant in the field yesterday who brings compassion and reality to this topic. When I talk about brain and behavior, from my experience, the first is the fundamental development of the brain, what's happening in the early years. I work with adolescents primarily, and I've really encouraged people to think about adolescence as the second period, biggest period of brain development, an opportunity because of that. Epigenetics are a really hot topic right now in terms of how does things like trauma impact the expression of genes and future brain functioning. Neuroplasticity we heard all about last night. But I strongly believe that there are ways for us to harness the power of the brain for our interventions, for the promotion of resilience. And when I think about it, I'm a trained cognitive behavior therapist. If I don't believe in the power of the brain and how we can change some of the neural pathways in terms of some of the automatic thoughts and behaviors that we have in our day-to-day practice, I might as well hang up my hat right now. But I've seen people change dramatically. And I know that their brains are changed as well because I've read the literature on functional MRIs and cognitive CBT. So I know that this plays a part in intervention, but also in terms of promotion of wellness. Number 5, access, wait times, and approaches to care. So if you talk to a bureaucrat these days, probably much in any field of healthcare or mental health care, any province, probably any country in the world, this is a hot topic because this is how the public measures whether they're having a success or not, but whether wait times are going down. Now, I have a fundamental problem with wait times as being the measure of our success because in reality, it's access to what? To what end? For what impact? So I've known people that have waited in the long line for months and months and months to find out that they were waiting in the wrong line, just to have to get into another line. I know people, for example, how many psychiatrists in the room? I knew you put your hand up. Thank you. And this is not meant to put you on the spot, but I know one family that waited 8 months to see a psychiatrist for parent training. I don't know a lot of psychiatrists that are trained in parent training. I know a lot of community providers that could have had access to in a much quicker amount of time that would have had great outcomes. So sometimes it's getting in the right line to receive the right service, to achieve the right impact. So innovation is very important when we talking about access and wait times. I think we're using technology increasingly, and we have different ways of even organizing our business. Should our shops be organized to meet our service providers, or should they be organized to meet when people actually need care? And I find out, for example, when people want to use evidence, it's when they have a problem or they have a question. That's their biggest chance of using evidence. A family is most willing to get help when they're in crisis or they need help right now. So some models like walk-in clinics have great promise for allowing people to access service at the time where they're most motivated to use it and perhaps engage in longer-term therapy if necessary. That family may be lost if they have to wait 8 months and may never come back again. Or the problems may become so severe that they're beyond what we can do to help. I think we're trying to organize our services so that it's less complicated for people, so they don't have to go on 12 waiting lists, maybe just one waiting list. And I do want to give a shout out to Strongest Families. Are our friends from Halifax here? Not this morning? It's ironic that I had this in and last night I realized that they were here. Pat McGrath is an old friend of mine. And it shows you how you can use even old technology. It used to be videotapes and now it's CDs and now it's a telephone to reach out to people to bridge the gap between need and service, especially in communities where you might be far away from service. Lots of therapeutic approaches that we're looking at. Brief therapies is something that the province of Ontario is looking at more fundamentally, not just because it's short, because there's a culture of care there that's different, which is really strength-based. And that's something they have to pay attention to. Peer support is exploding as a viable complementary form of care. But at the same time, we're looking at what kind of accountability has to be there for part of peer support. What kinds of links to more formalized services have to be there? What's the partnership between traditional care and peer support? And all kinds of traditional. When I talk about traditional, I'm talking about perhaps what we can learn from our First Nations communities in terms of traditional care and also alternate therapies. We did a study years ago looking at auricular acupuncture for self-injurious behavior. That might sound weird to you, but the addictions literature has some promise in that area. We couldn't find anybody to review it. Nobody felt confident enough to review that alternate therapy, which actually showed a decrease in the frequency and intensity of not just self-injurious behavior, but also the urges to harm. So we have to be open to different things. That was probably the most out there thing that I've ever done, and learned a lot from the colleagues that I did it with. Parent youth engagement. How are we doing for time? I'm great. Well, you're great too. Parent youth engagement. This is a tidal wave that we can't ignore. We actually have to embrace. Some of us have been doing this for 20 years when it wasn't cool to engage young people in meaningful ways and engage families in meaningful ways. We shouldn't be doing anything, whether it's designing a system, building a building, organizing our services, advocating with government, designing research studies, without meaningful participation of young people and their families. And I'm going to just check. So at our center, we actually believe that parent and family engagement are evidence-informed practices. There's enough of a knowledge base now to show us that when parents and young people are meaningfully engaged in their own care, they have better outcomes for whatever evidence-informed practice you use. It's a necessary component. It probably accounts for more variance than the evidence-informed practice itself. We know that young people that are engaged in meaningful ways in things bigger than themselves are healthier physically, are healthier mentally, engage in lower risk-taking behavior, and have a reduced risk for suicide. And the organization or activity in which they're engaged benefit from their creativity, from their energy, and what they bring as people to that activity. So it's huge. I think I have time for a story, and after hearing the storyteller yesterday, I'm almost afraid to tell a story. How you doing? So just to give you a sense of how tough youth engagement is, I learned the hard way. Years ago, Simon Davidson, a very close colleague of mine, and I developed a program called YouthNet. It's having its 20th anniversary next year, which is for us huge. The program's been around for 20 years off the side of someone's desk. It doesn't have any government funding. It's always been something that we've believed in. So very early on in that program, it's a for youth, by youth initiative around mental health promotion, early identification. We had the opportunity to present our model to Health Canada. Health Canada contacted me and said, Dr. Manion, we've heard about this thing that you're doing. We'd like you to come to speak to our directors and managers. And please send your bio and send us your slides in advance. So I contacted them. I said, that's not the way we do things at YouthNet. I said, we do things with youth. They said, well, that's right. Bring a youth. Send us their bio. And send us their slides. So we presented this to our group of young people that were engaged in developing this program. And Simon and I were there with 7 other young people. Oh, sorry, we're not young people. 7 young people. We feel young. And they said, well, this is a huge opportunity. This is great. We should all go. And I said, well, come on. We have 45 minutes to talk to directors and managers at Health Canada. We can't go with 9 presenters. It's just unheard of. And they said, let's put it to a vote. Of course. So the vote was 7-2. And we went, 9 of us. And we went a half an hour early. And the young people put words all around the boardroom. Respect, engagement, encouragement, positive, reinforcement, youth power. And then the person that was going to do the lead for of our talk was a young person. And then the managers and directors from Health Canada came in, and they kind of looked like they were, oh, this is not what we expect. Oh, no bios and no slides were sent in advance. And not a slide was used. And we lined up, 9 of us, and we took turns talking. And we talked for an hour and a half. Can you imagine? We only had 45 minutes. They talked for an hour and a half. How am I doing? Still okay? And Simon and I had 1/9 each of the airtime. And then we left. The next day, the guy who had invited me said, well, we're giving you $300,000. And just to let you know, the only reason you're getting it is because you walked the talk. So we were wrong. If we had gone with just one young person, had done something traditional, it would have been one more presentation to managers and directors at Health Canada. What we did made them stop and think. and cancel their next meetings and stay engaged in the conversation. So sometimes engagement gives you things you don't anticipate, and you have to be willing to take that risk. That was a huge risk with great impact. So just a little story. Awareness, literacy, and competency. And you see I have a circle of people sitting around here talking. That's because, and no disrespect intended, what I'm doing right now is probably the worst way to engage in any kind of knowledge sharing. Because I'm talking at you for 20 minutes, maybe 25. Talking at you for 20 minutes. The real way that we learn things is by developing relationships. And that's where I want to applaud you, because you've organized the day so that there are opportunities for relationships to build. At the end of the day, you're actually kind of goosing that a little bit, right? So you're priming the pump so that relationships can transcend this meeting. So when I talk about awareness, literacy, and competency, I'm talking about all kinds of different things. I'm talking about what should everybody that deals with children and youth know about child and youth mental health. Whether you're a teacher, a family doctor, a police officer, a lawyer, a coach, what's the fundamental knowledge that we should all have about children and youth in the roles that we have with them? I would include parents and youth themselves, by the way, in terms of what we should know fundamentally. What's the pre-service training we have for our professionals right now? If you think about it, that's part of the problem. We train our social workers over here. We train our psychologists over there. Our family docs are over there somewhere. The psychiatrists are back here somewhere. And when we're all done, we say, okay, now you have to play together and respect each other's roles and understand what your responsibilities are mutually. We haven't been trained that way. We've been trained in silos and then expected to work as a team down the road. So there's some things we have to change in that regard. We also know, as we're using evidence in our practice, well, keeping up with evidence is hard. It's challenging. If we're using evidence-based practices, so some of these packages that have been well researched and now they've become products by purveyors to sell to people, well, if you want to keep up with the evidence, that means you're buying a new product every few years and retooling your workforce every few years. And is that sustainable? I know others of us are talking about, and work of people like Therapeutic are looking at core elements or common elements or modular approaches to care, where we're perhaps even in our pre-service training, we should train everybody in some of these core elements and make sure that the workforce can be refreshed over time. And how do you refresh that workforce? So a lot of initiatives talk about training or capacity, but they don't talk about supervision. They don't talk about mentorship. They don't talk about coaching. And put resources aside to make sure that can actually stick. Anything that we're teaching can actually stick. Who here has a mentor? Okay. I think everybody needs to have a mentor, no matter where you are in an organization. I have mentors. I have more than one, because not everybody can mentor me in the same thing. I have mentors for different things. And I really encourage, I have two people here from the center, and they know that I believe in mentorship, and I encourage them to get mentors outside of the organization, so they can bring new knowledge and experience and insights into the organization. And the last thing is, if we're changing our workforce, well, how do we scale that up? How do we train across every corner of the province? How do we use technology? How do we use training the trainee and champions to be able to scale up the things that we really need to do across the province? Transitions. Very hot topic in terms of what happens after people age out from our services. There's this big schism between child and youth care and adult care. There are problems that we deal with in child and youth mental health that aren't problems when you get to the adult system. They aren't severe enough or within their frame of reference to value comprehensive approach to care. How do we prepare young people for that transition? I used to be a psychologist for the nephrology unit at the hospital. So I work with kids on dialysis all the time. And one of my jobs was to actually prepare people for transition. We started 2 years before they had to transition to prepare them for that transition. Are we doing that? Especially since we have to recognize that more and more children and youth with mental health issues will probably have chronic issues that will relapse and remit. I'd love to think that we can make things go away forever. That's not reality. I think people have styles that stick with them that will come up again at various times in their life. So if it's a chronic condition, how do we prepare them for that? By making them more resilient in terms of their own self-care and equipping themselves to manage themselves, but also in terms of having to deal with a different system down the road that may not quite work the way that we worked. Go beyond transitioning. Think about different kinds of transitions. Think about transitioning from a place like Lutherwood back to the community. Think about transitioning from a hospital to a place like Lutherwood or to the community. Think about life transitions for a family, for an individual. Think about transitioning to the workforce as a young person who's not going to college or university. Lots of work going on right now in mental health in colleges and universities because they are bastions of all kinds of capacity, right? Because they have all the answers within their walls, so they don't have to talk to anybody else, right? The reality is universities are some of the most insular places around. So they don't share. We talk about brag and steal. You talk about what? Rob and duplicate? I like yours better, I think. So we have to do this better, and I think that there's some models that are emerging, some things we've learned from other places like Australia and the UK, and some things we're building here that others are looking at. So watch this as an emerging theme. Philanthropy and service delivery. Child and youth mental health right now is a very hot topic. Everybody wants to get into the business of child and youth mental health now. Industry, like 20 years ago when YouthNet started, we approached industry to help with YouthNet. And people were very reluctant. One organization gave us money on the condition we never mentioned their name because they didn't want to have their brand associated with mental health or mental illness. That's not the case anymore. That has changed. People are standing up proudly and saying, we are champions for child and youth mental health. And I have just a few of them that are here. I'm just going to change. So good things and bad things. When corporate Canada stands up and says this is important, that helps to reduce stigma because the conversation can take place. Lots of role modeling. Hopefully they're looking at the mental health of people in their own workplace and the kids of the workers that are working with them. Usually that's what's prompted them to make that investment. They've asked their staff, what topic, what issue should we as an organization invest in? More often than not, child and youth mental health is what comes up. That's what happened at Canada Post. That's what happened at RBC in terms of the focus of their philanthropy. Downside, they don't know what they don't know. So they want to go in and fix things, and they don't necessarily know what the evidence says. They don't necessarily know who's doing what. They don't necessarily know what's already in place. So they tend to reinvent the wheel a lot. And a good example is when Bell Canada funded a $1 million website in British Columbia, at the University of British Columbia, and everyone was applying. That's great. The website that they wanted to develop had been created and was functioning across the road from the university. It existed already, but they just didn't share the information. So the other thing is, when philanthropy is there and they have dollars, they wave $1 million in front of us, and because we're all wanting in a very poorly resourced system, we all want to compete for that $1 million. And that increases our fragmentation and our competition and our infighting, and that's not a good thing. So more and more of us have started to talk about how we have to make sure that we align philanthropic efforts, that we get them to work together. I've encouraged them to all come in one room. There's a lot of work to be done. Parcel it out. Talk to each other. Figure out what's already going on. And I think that they are starting to listen to that. Succession planning is my number 10. That's because people like John and I are getting older. And we have to think about what's the next generation going to look like in terms of child and youth mental health leadership. And it's probably going to be different people with different skill sets working in different organizations to meet different kinds of needs of people. We have to have different skills. We have to understand business. And I think John's a good example of that, but I don't think you learn that in school. I think you learn it in the school of hard knocks. Knowledge exchange. We have to be technology savvy. We have to understand that our workforce is different than the workforce that we belong to, so the generational differences in terms of our workforce. And we have to think about things beyond our organization. I think good leaders now have strong organizations. Good leaders in the future will have strong communities, strong networks, will have a view of the bigger picture, which works contrary to everything we know about how to maintain and sustain an organization. Because we can't just look at ourselves. We have to look well beyond ourselves and sometimes step aside and let somebody else do the work that we thought we should be doing. Huge opportunities to align the training of that next generation. So there are some honorable mentions. The top 10, very quickly, school-based mental health, very hot topic. Stigma reduction, but not just stigma reduction, the impact on service. So when Offord said 1 in 6 people with children and youth with mental illness access service, if we reduce stigma, which is one of the major barriers to that, let's say 2 out of 6 now goes to get service, or 3 out of 6. Do you think our systems of care are equipped to deal with 2 or 3 times the demand that we're already facing? 3 out of 6 would be half of those who need it, and we would be overwhelmed. So we have to think about the impact of that. Mental health and human resource planning. There is no mental health human resource planning. We don't know how many of what discipline, what skill set we need to meet the need. We're not even sure of the need. So we need to do some thinking in that regard. Youth suicide prevention, my topic of great interest. Self-care for mental health professionals. Do we stop, pause, and reflect about what we're doing to our staff? In child welfare, a new social worker in child welfare lasts, what, 1 or 2 years before they burn out? In education, they're losing educators. First 5 years, they lose about 40% of their new educators. And what about those that are working with children and youth? And compassion fatigue. And how do we make sure that we're equipping them to be well in their work? Child and youth mental health in the workplace is important, and social media. Our center has been around now, well, almost 10 years. We touch most, if not all, of the topics that I just raised. We view ourselves as a catalyst. We bring people and knowledge together to improve care, which means that we have to work effectively with people as they are also changing. And we take our work very, very seriously because we know you take your work very, very seriously. And we're just one tool at your disposal. And with that, I thank you.